Good evening, everyone, and I welcome you all to the sixth episode of PAX International Web Symposium. This is one of the most important episodes for me, and I was really looking forward to it because we do a lot of interventions day in, day out, and there are a lot of situations where we face a lot of emergencies and can't understand what to do, what's the best thing to do. Still, there are a lot of things which is not very clear for everyone what to do when the situation goes bad, or what situation can go bad is also very important for us to know. So we are here with our international expert, Professor Konstantina Kontogianni, with whom I had the privilege to, work, observe a lot of intervention when I was there in Heidelberg in 2023. So it has been 3 years, and she was there with us in Octane PAX 2025, and we had her lecture over there, and we'll be just reliving that moment because everybody was, I wanted everyone to be a part of it. If not, offline, then yes, offline is always the answer. And we have this concept with PAX International Web Symposia, and we'll going ahead with Professor Kontogianni, lecturer of Octane PAX 2025.
So there are different types of emergencies in the bronchoscopy room. They have many differences, but one thing in common, and this is time. Time is important. If we do not act quickly, and if we are not effective, then the patient's life is in danger. We have three types of emergencies. We have the foreign body aspiration, we have central airway obstruction, and also hemoptysis. Everybody knows this. I will try to touch everything in the next 30 minutes and give you an overview, and please, I welcome any questions about this. Starting with the foreign body aspirations, what kind of foreign bodies do we have? We have visible in X-ray. This is the easy case. So teeth, needles, and metal parts of tools which can be swallowed. But we have also foreign bodies which are soft, which are not visible in X-ray. And then the anamnestic of the patient is really, really important. What are the hints that we have from these foreign bodies? We might be able to see atelectasis. They are indirect visible. We might be seeing post-obstructive pneumonia there where the foreign body is. We might be seeing a hyperlucent surrounding lung on the X-ray to give us a hint where it might be. Decrease in pulmonary vascularization around it, surrounding it. So if the anamnesis fits, then look for these special signs on the X-ray. What kind of foreign bodies in adults? We can see actually most of the time we see food, nuts, meat, bones aspirated, but very often teeth, especially after dental procedures. We might see chewing gum, needles, nails by adults. In cases especially of intoxications, in patients that suffer seizures, after reanimation, we have often teeth that are being aspirated. Patients' psychiatric conditions, patients that swallow and aspirate everything possible, dysphagia after stroke, elderly patients, but also children, very, very important here. Children swallow most of the time, and it doesn't go to the esophagus, but to the lung. Toys, food, especially nuts or small pills, which are very dangerous. So this is what we have to take care. Even if the patient is completely stable, we should not wait to do the bronchoscopy later the week. Why? Because they might move and then directly cause hypoxia due to central airway obstruction, but they will be causing post-stenotic pneumonia. They might cause atelectasis of the part that they're occluding, hemoptysis, especially if they are really sharp needles, for example. They might penetrate the wall and go to the vessels, perforate the airways, and also corrosive effect, batteries, but also pills. Magnesium tablets, for example, there are case reports of them causing ARDS. So this is an emergency. We're not allowed to wait many days until we remove them. Which are our tools? Rigid and flexible suction cup. This is very important. Most of the time, or if we're lucky enough, we might be able to just suction a soft piece of meat only with a big bore catheter, suction catheter. If we don't succeed like this, we will be needing flexible or rigid forceps. So this is a way to remove them. The cryoprobe was really good with organic material, and the basket for everything. So these are our tools. Which procedure is preferred? We prefer the rigid bronchoscopy because we have a secured airway the whole time, and with the rigid I have more space, so I can remove bigger foreign bodies. But we can intubate the patient also with a flexible tube, secure the airways. In this case, please choose a tube with a large diameter, so the 9 millimeter if possible, because sometimes the foreign bodies, as I told you, are big and it's really hard to take them through the ET tube. I have here a video of a tooth which I tried for a long time to remove because it was stuck in the right lower lobe. It happened and it really worked well with a basket. And this is a very good tip, have a plan B always. So I'm moving the tooth back, and then I see there is no way that it's going to get it through the rigid scope. So it doesn't pass, no matter how I turn it, no matter in which it's really big. So I have to have a plan B in this case. And the plan B was to secure it in the distal tip of the rigid and remove everything and block, with the hope that I'm not going to lose the tooth again, and it will occlude then the airways. So you see here, slowly, very carefully, moving back the tooth together with the rigid and succeeding to remove it. This would not be possible to do this with a ET tube. So this is why I say we prefer the rigid if possible. This is another foreign body and dental bridge. And if you can appreciate here, in the X-ray, it's really sitting very dangerously. Patient was coughing all the time. We have to remove it immediately and hope that it will not perforate the wall there. Going to the second part, the central airway obstruction. Have here the next video. This was a patient, 50 years old, female, with cough and shortness of breath. First diagnosis, obvious lymph node coming in the airways in the central, station 7. This was a central tumor, but we didn't have a diagnosis up to then. You see a little bit rest lumen on the right side. I could pass with a bronchoscope and see the periphery, the distal. The left side was almost totally occluded. So difficult case. What do we do in these cases? We have central airway obstructions, which are malignant and benign. The benign stenosis, multiple etiologies, most often post-traumatic strictures. We have a lot after tracheotomy, intubation. We know this long-term ventilation during COVID. We have many patients with tracheal strictures coming up. But also amyloidosis, CGPA, sarcoidosis can cause central obstructions. Benign tumors like lipoma that you're seeing there. More rare is tracheobronchopathy osteochondroplastica. If you have seen it once, you'll know it forever. Not a lot we can do there. And also idiopathic stenosis, especially like most than 90% of them are being female patients coming with this. Malignant stenosis, obviously bronchial carcinoma, but esophageal carcinoma also. These are the most frequent ones. But we might have a lymphoma, which is causing a central obstruction, laryngeal carcinoma, thyroid, and all different metastases. What do we do? There is a treatment algorithm. If we have a life-threatening situation, then we prefer rigid bronchoscopy, therapeutic, trying to debulk, try to free open the airways. If it's not life-threatening, then we can do the flexible bronchoscopy, locate the foreign body, see how big it is, see what we can do, and then, if needed, switch to the rigid bronchoscopy. What tools do we have? We can do the mechanical debulking. We can use the hot and cold techniques for the central airways obstructions, and we can implant stents. In order for a patient to be symptomatic from this central airway obstruction, it has to be at least 50% of the lumen of the distal trachea obstructed. So this means that the patient that we have, especially younger patients who have really big obstruction and not even knowing this and noticing it when it's too late or when it's really late, when it's an emergency. As you can see here, we can use the ablation like laser, APC, or also the mechanical debulking when we have an endoluminal tumor or a mixed tumor which is extraluminal and protruding, infusing the trachea. Brachytherapy, cryotherapy, and photodynamic therapy, they are all of them giving results later. This means they are not good in an emergency, and especially not, of course, not useful if we have extraluminal tumors. In case of extraluminal tumors which are protruding and causing obstruction, stenting is the only thing we can do because we need the radial force to expand the lumen of the trachea or the bronchus. As I told you, direct effect, mechanical debulking. I debulk and then I have a directly reopened airway. Cryorecanalization, stent, laser, all these have immediate direct effect. Cryo, brachy, and photodynamic therapy. The three of them are very good, but have a delayed effect, are not for an emergency. Starting with mechanical debulking, what can we do? We can work with a rigid tube, do the coring out. We can use a flexible or rigid pincer ablation. We can use a microdebrider that you see here, and then suction the tissues and clear the airways. If you have a complex scar stenosis, balloon dilatation is the optimal way to proceed. And depending on the stenosis, at the level of the stenosis, we dilate the balloon until we have a good result and wait a little bit so that we have the result, the dilation that we want, and it's persisting. Going to the hot and cold techniques, and starting with the hot ones, we can use laser for the central airway obstructions. We can use the electrocoagulation, microwaves, and APC, argon plasma coagulation. About laser, the most often one is the Nd:YAG laser, and we also use in medicine the CO2 laser. You see the differences in those two. Nd:YAG laser is better in coagulation, but has not an excellent cutting precision. The CO2 laser has very good cutting precision, but does not coagulate a lot. So depending on what you have in your hospital, if you have laser, the depth of penetration of CO2 is minimal, 0.1, and the YAG laser goes deeper. What we do is we succeed in tissue destruction with high energy light, and this way in a non-contact mode. This is also important. So we have to have a relative distance from the tumor. With laser, if we go more than 50 degrees, we have the hymeremia, and this is what happens in the depth. Then more than 100 degrees coagulation is succeeded here, so it doesn't bleed a lot. And when we reach more than 300 degrees, and this is what happens in the core, there we hit our laser, we have the vaporization and carbonization of the tissues. So these are safe techniques, not causing a lot of bleeding if we don't perforate the vessels, of course. Depend on the distance. The closer I am to the tumor, the more heat I have. The further away I am, it might take longer, but I can control the laser better. This is a small video, an older one. We do not have the laser anymore. We work a lot with APC, but you see, tracheal tumor, endoluminal tumor takes a long. Look at the pointer of the laser, and we are just hitting from the surface, luminal surface, not from the wall We start from the center and work our way to the wall. We don't have to remove everything in an emergency. As I told you, clinical symptoms more than 50% obstruction. So if we manage to debulk and not completely remove, it's a very good result for the patient. High frequent alternating current, electrocoagulation, everybody knows this. Tissue distraction through thermal energy. This is a contact method. So we have our tools with contact with the tumor. We achieve a devitalization in temperature for 50 to 60 degrees. And then the devitalized tissue is broken down by metabolic process in our body. We have here coagulation at 60 to 80 degrees, drying off tissue more than 100, carbonization more than 200 degrees, and vaporization, again, when we reach 300 degrees and higher. Our tools, the snare, really nice way to cut, especially, it by lipomas or carcinoids. It's a very nice way to remove them. Electric knife or hot biopsy forceps. We do work a lot with argon plasma beamer. This is another non-contact method. This is a flash effect. We have a plasma jet, which conducts electrons, and in this way it heats up the tissue. There are different. Our tools are the APC probe, which is axial beam, which can be a side fire effect, or the circumferential beam. There are different to choose from. If there are thicker ones, thinner ones, we can really nicely not only coagulate, but also remove tissue like this with the same effect, the carbonization effect of the tissue. And you see here the APC, trying to stay away, not get contact like here with the wall. It's not always very, very easy. And then slowly carbonize the tissue and then remove the stenosis. About microwaves, we know microwaves in microwave ablation of liver, of now from also lung tumors, but it can also work for central tumors and to ablate them and to relieve central obstruction. This is a study from 2022 with 8 patients. The first study mentioned the targeted temperature is here 80 to 90 degrees. There are polar molecules which rotate back and forth to the probe. So this is a different way of working, like microwaves work. They did achieve complete recanalization of the lumen there without complications in the study. So we might be able to use it in the future in our unit also. These techniques have complications. And looking at this one, first of all, the hot techniques. We have to be really careful about FiO2 reduction, lower than 40%. We go at 30%. Safer, we feel safer with 30%. Decrease the energy. Pulse mode instead of continuous mode might help with this effect. And take good care of your probe and have good distance from the tube or the plastic stent, because this might also, the normal stents, the metal stents, this might fire. Bleeding, another complication. So we have to coagulate sufficiently. Bleeding doesn't really happen with the hot methods, only when we perforate a vessel. And then we have to be quick. Then most of the time, then it's a big bleeding. What other problems we might have? Perforation. So perforating, we have to go tangentially to the air wall and not directly to the air wall. We have to if we don't see the distal lumen, we have to be very, very careful, especially with laser, because we might perforate in the distance when we use it. And also begin from the free lumen, as I told you, and go to the wall and not the other way around. About hypoxia, we keep the distal airway free, try to keep the distal airway free, or secure, if our obstruction is on the right side, then secure the left side. If it's central trachea, we might work with mini catheter, mini jet catheter. We have to find another solution in order to avoid the hypoxia. Going to the cold technique, the cryorecanalization, here we work completely different, minus 90 degrees almost. Cryosensitive tissue is tumor and skin granulation tissue. Also, cryo is very good for granulation tissue removal. So we can work nicely if we have central tumors. Activate for a few seconds. The longer we activate, the bigger the chunks of tumor that we remove. 3 to 5 seconds, we might activate longer. And pull out the probe abruptly, because we need force to remove it together with the bronchoscope. Be aware, bleeding risk. So we are not coagulating here like in the hot techniques, so we might face severe bleeding after it. The longer you freeze, the bigger the chunks of tissue that we remove, and the bigger the probes that we have, the cryo probes, of course, the bigger the results. So we can choose depending on how big the obstruction is. Have here another video, right upper lobe tumor. This is not an emergency, but this is a recanalization of the upper lobe. You see, we try to move the cryo probe in the middle, not touch the wall, because in this way we will remove also parts of the wall, and then in one go remove a good part of the tumor, releasing and reopening the right upper lobe. What about stents? More than 20 types of stents. We have the silicone stents, self-expanding stents, especially for peripheral, for bronchial, for the right main or left main bronchus, dynamic stents. We have custom-made stents, drug-eluting, all kinds of stents. In the emergency, most of the time we need a Y stent, because we have to secure the right and the left side. Malignant central obstruction, when we do have the bifurcation syndrome, as I showed you in the first video, or a big tracheal obstruction. Tracheoesophageal fistulas are also an emergency. We have to secure it, implant a stent, and then occlude the esophagus, the fistula. Benign stenosis is a rare indication, but we might need to do this as bridging in, for example, compressor of a huge goiter. We might need to implant a stent with radial force to keep it open until the patient is operated. Don't forget about tension pneumothorax. After a lesion in the posterior wall, we might cover up this leakage with a stent. This would be also an emergency indication for stents. You see here the CT of the patient before, that I showed you before. The central endoscopic view, and after the recanalization, the Y stent in there, and then we got, of course, enough tissue for biopsy, and we started with a chemotherapy in this patient. You see the rule about the Y stents. Silicone stents are for benign stenosis. Metal stents are for malignant stenosis, but there is one big exception, and this
Professor Konstantina, I request you to please summarize quickly, because your time is up.
I have 30 minutes according to plan.
But they are ringing the alarm, I suppose.
Have 30 minutes according to plan. I'm going to talk about hemoptysis, so
Okay, please proceed.
Yeah. Dehiscence of anastomosis, for example, when we have transplant patients and we have a dehiscence, then we might need temporarily uncovered stents, because uncovered stents cause granulation tissue, and then in this case, we can fill and succeed in granulation formation and closing up the gap of the dehiscence. This is the only exception in this rule. What we need is high radial expansion force. You know about the implantation, 2 guide wires, right and the left side for the SEMS, and implant it and rigid if it's a Y stent under a C arm. Complications of stents, think secretions, especially if the patient keeps smoking afterwards. This is catastrophe if he smokes. We have to give them inhalation, saline, high percentage saline. If the stent is really high, then it might cause cough, dyspnea, and dysesthesia for the patient. If it's really close to the cricoid cartilage. Stent dislocation, perforation is another complication, and stent rupture, as you see on the first picture on the top. And granulation tissue is the most often. You see the distal end granulated, and here in the Dumont stent, as you can see here, almost completely covered from granulation tissue. We can remove it with a cryo, we can remove it with a forceps, we cannot remove it with a hot technique. Don't forget about this. So absolutely no smoking, inhalation therapy, physiotherapy, optimal secret movement, keeping the lungs free. This is an only example of mycosis, recanalization of a stent in a patient who developed mycosis after we implanted the stent, and we recanalized a long procedure with success afterward and gave also therapy. Going to the hemoptysis, I'm not going to take any longer. Mild, moderate, and massive hemoptysis, depending on how much blood comes out approximately in 24 hours. Massive is 30 to 50 milliliters per hour. What do we do if the patient is unstable? We have to intubate. If the patient is stable, first do a CT in order to have an idea where the blood is coming from, and then go to the bronchoscopy. Suction and compression, endobronchial application of cold saline. This works really, really good, but also other vasoconstrictive medication for more minor bleedings and not in a massive bleeding. APC, laser, can coagulate really nice if we see an endobronchial visible bleeding. And a tamponade, rigid or a flexible swamp, tampotamp, balloon, stent, the spigots. There are many tools that we have in order to stop peripheral bleedings. If we have to intubate the patient, we might intubate the contralateral side, the one that is not bleeding, or intubate centrally and then push a balloon catheter on the bleeding side and occlude it so we can ventilate the patient. Or a double lumen tumor tubus is also possible, occluding the side that's bleeding. What our goal is to win time for the interventional radiologist embolization or operation. The last take-home messages, multimodal treatment concept. This is really, really important. We have a lot of methods for these emergencies. Depending on what your hospital has, we don't have laser, for example, we use APC. Comparative studies are not existing, and it's not ethical to have comparative studies in this. Experience is very important. Think that time matters, and talk to your colleagues in the hospital and work with them together also in an emergency. Thank you very much for listening. Thank you.
So, I had an opportunity to listen to this again, and I'm pretty much sure that I got to learn a lot more in this episode when I was compared to there, because of the distractions we have in the offline and physical present conferences. It was very, 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 I must say, elaborative, and whatever doubts we had in our minds is almost very much clearer now. But still, I would request Professor Kontogianni to please reflect back on this video of yours. And do you want to add something? It's like 7-8 months have passed since that last video. You want to add something on it?
I think covered the main parts, the main emergencies that we can face: obstruction, foreign body and blood, hemoptysis. I don't know if you found, if you're missing something. This for us, emergencies like a life-threatening, of course, condition. You have to be quick, you have to be effective, and you have to have a plan B. These are the three most important advices that I have from our experience, from my experience in everyday bronchoscopy. It can happen without warning, and then you have to really have a plan in your head. And also the nurse has to have a plan in your head. The nurse in the room, extremely important parts, an experienced nurse who knows which tools you will be needing, who knows where they are, because time is really important. These are the keys of successful treating or dealing with such a situation.
Thank you, ma'am. So, We have with us our PACS expert, the program lead is Dr. Sonia Dalal, ma'am, consultant pulmonologist, founder and director, Kalyan Hospital from Vadodara. You want to say something, ma'am? You want to add something?
You must have protocols and SOPs in place, Kanishka. This is very important. And maybe whatever procedures that you're doing, you should basically have a map how you're going to do it. And with a backup plan also, what if something goes wrong? What are you going to do? So you need to discuss this with your team. And as Professor Konstantina said, you must have a trained staff with you. If the staff is not knowing where you are going, because they should be designated a particular job to be done. So if I'm doing a bronchoscopy and if a patient has a massive bleed, my staff should know that they have to give me a Fogarty catheter, and the anesthetist should know that ventilation and oxygenation is very important at that point of the time. So you must have all protocols and SOPs in place, right? And everything needs to be discussed during the procedure and before the procedure also with a map. This is what I believe.
Thank you, ma'am. Very important point, and you described it very well. The situations and scenarios which we can get in the operation theater. Now, I hand over this session to our moderator, Dr. Mohit Kaushal. He's a consultant pulmonologist from Fortis Hospital, Mohali. Dr. Mohit, please.
Thank you, Kanishka. A very good evening to everyone. On behalf of PACS Organizing Committee, it's my great pleasure to welcome you all in the 6th International Web Symposium. So we are honored to have such a esteemed speaker with us, Professor Konstantina. She has, difficult things looked so easy in her slides, which, definitely cleared most of her doubts, then how to proceed and when to proceed and what not to do. And we also have a program lead. She's already into something live happening there in Vadodara. She's Dr. Sonia Dalal. She's a director at Kalyan Hospital. She's already into something severe case, which we are talking about. She's going to do that soon. So I would like to, introduce our esteemed group of panelists, expert panelists. We have Dr. Nishanth, consultant at KIMS Hospital, Tamil Nadu. We have Dr. Dimple Makhija. She's a consultant pulmonologist at Shri Balaji Group of Hospitals at Raipur. And we have Dr. Vijay, who's an associate professor at the Department of TB and Respiratory Diseases at Shillong. So bronchoscopy is a vital procedure, from bronchial washings to airway stunting, from doing diagnostic EBUS to debulking, so and so forth. There are a lot of procedures called as a very safe procedure, less than 1% risk, high risk things are going to happen less than 1%. But the more you add to the tools, the more things you do into that 10 to 12 centimeter of a windpipe, which is a very small area which you work for, and more the complications can definitely add to it. And that, as ma'am said, professor said, that time is very important. Because in such a small area you're working, time it's going to be the main support of yours, or the main tool. You should use it before it can go bad. So let's start the discussion about the few of the questions we can put to our panelists, expert panelists, and then definitely expert opinions from the same questions from Professor Konstantina and definitely from Dr. Sonia Dalal as well. So my first question to Dr. Nishanth. So Dr. Nishanth, do you have any checklist before you go for your bronchoscopy procedures? And how do you approach the patients with a high risk like COPD, asthma, maybe a cardiac comorbidities? So how do you go about these people, these set of patients?
We have to have a detailed clinical history of the patient and from what the symptoms started, and have a detailed his ECG cardiac workup is really important, because when the patient is subjected to stress and strain during that time, there can be arrhythmias, and even if the patient is having a moderate LV dysfunction, it can turn to severe LV dysfunction at that time. So a cardiology workup and a fitness from the cardiologist is important. And if you have a good MAC in your facility, let's say monitored anesthesia care, a PAC can also help. Like I am telling about a planned procedure, but if it is an emergency, if you can have a critical care team or a anesthetist with you, then the workup becomes more important. So basically, telling it in one line, an ECG, and basically like whether the patient is having any on any like DAPTs or any like aspirin, clopidogrel, or any of the DAPTs which carries increased bleeding risk, so that you can have a note about what you are going to do with.
Do you have any checklist also that these are the things for definitely for a even for a basic bronchoscopy that you tick those things that yes, these things are has to be done prior to that,
yes,
including a consent, and then you proceed. So do you have that written checklist with you?
Yeah, written checklist. Like one thing is like obviously one thing is cardiology consultation. Then you have a PSC workup, and one more thing is like a if you can have a this previous CTs if you have anything, and the current CT which is a recent one. Then also you have a like the medication. What are the patient currently the medications the patient is on? Then what you can say the consent, which is really important. The consent, which is really important, because without the consent you cannot, and you have to explain in detail to the bystanders that what you're dealing with, and what like how much outcome you can expect. Because whenever there is critical emergencies, like we are actually dealing with life, so you have to explain in detail to the bystanders what you're dealing with at that time. And one more thing, and what are the previous medications the patient is on, and the comorbidities should also be checked into, and whether the patient is having a recent MI, whether the patient is having a recent stroke or any like recent coronary cardiac events, which can put the procedure into a more higher risk. And what is the age of the patient? If you are doing the procedure as a palliative one, or whether it is a like emergency or a treatable cause, because palliation is like just like a as a central airway obstruction if it's a palliative, or for a hemoptysis case which you are doing as an emergency one.
So anything to add, Professor Konstantin?
I think the last point was very, very interesting, and thank you for this. I mean, the indication of a bronchoscopy is the job of the bronchoscopist. So this is our job, and if we decide, knowing the facts and knowing the history of the patient and his disease and why they ask us to do this bronchoscopy, we have to decide if we're gonna go continue and do it or decline, because of the risk is so high, and because we have to talk to the patients and the family of the patient if we decline a bronchoscopy due to high risk. I think all of us are used to treating and doing bronchoscopies on very sick patients. So every patient is a potential really, and every bronchoscopy, even the simple one, the simple washing, can end up really other as expected. So we have to inform the patients, and we have to decide for ourselves if this is a necessary bronchoscopy or not. This is a very important point.
My next question to Dr. Dimple. So Dr. Dimple, what drugs you use for local anesthesia and or conscious sedation without the anesthetist present in your bronchoscopy suite? And what are the possible adverse effects you have seen or we can see during that use of local or a conscious anesthetic agent, which we daily use in our bronchoscopy suites?
I think Dr. Dimple has to go because of some emergency situation, family reason. So,
do we have Dr. Vijay with us? So, I think I'll pass my question to Dr. Vijay.
Very good evening, everyone. I hope everyone can hear me.
Yeah.
Yeah.
Yes.
Yeah. Yes. So, for routine daycare, I personally use is Dignocaine. For the pre-procedure, we would use a Dignocaine spray in the oral cavity, and then proceed on with Dignocaine jelly when we going for the nasal tract, and then use a spray as you go technique as we enter the airways. One common feature which I have seen is that we sometimes use the transcricoid distillation of Dignocaine. And I have noted that definitely there's a decrease in the cough reflex makes the transition of the vocal cords easier when we use a transcricoid installation of lignocaine. And with regards to the strength of lignocaine, normally what we use is 2% lignocaine, but in fact, a colleague of mine had done a thesis in during his during his DM studies where they compared the use of 1% and 2% lignocaine or anesthesia, and what they found that there was no significant difference. And using 1% actually increased the amount of the volume of lignocaine that was used. So of late, I also have been trying with 1% lignocaine, and it seems to be working just as fine for local anesthesia when we're using it as a daycare procedure. And for most patients, we don't usually use any sedation, but if needed, for example, if we have to do bronchoscopies or EVAs, daycare EVAs under local anesthesia, then we would then I would use sedation with the midazolam and IV fentanyl. So this is just the basic uses of anesthesia analgesia for patients in daycare. But for more complicated procedures, definitely we would prefer to put them under general anesthesia. It makes the procedure much more easier and more comfortable and less stressful for the operator.
Have you ever encountered the lidocaine toxicity or any adverse effects with these drugs?
So far, no, sir, not yet. But definitely, I've been using. I have been using lidocaine, so definitely, maybe that is one reason. But so far, I have not really encountered any serious adverse effect with lidocaine on local anesthesia.
So if it happens, what to be done?
Probably the most important thing is that I think the most important thing would be pre-procedure, just to rule out any if the patient has any risk factors for any cardiac arrhythmias or any sensitivity to even though we're giving it as an installation, it has a prior history of certain reactions. If he's had a history of certain reactions, and then we have to be more careful. And if it has a history of so anything like that, risk factors, then definitely we need to have a proper cardiac evaluation prior to procedure and have the anesthetist on standby in case we need the anesthetist help in such a complication.
Can I ask one question if the panelists allow? I mean, if the moderator
Yes,
allows? Yeah, so I'm asking to the august panelist, every one of you. Most of the books do say that you should not exceed 7 milligram per kilogram of xylocaine. And we normally don't take the cognizance of how many doses that we are using it. When we initially give a nebulization of xylocaine, then we give a transtracheal of xylocaine, and then once we are at vocal cord, we flush it. Then we flush it at the carina, and then the moment the patient coughs, we tend to do it. I'm sure. I mean, how many of you calculate how much we are giving it? And normally it is said that you should give up to 7 milligram per kilogram. So, Konstantina, I just wanted to ask you. I mean, are we doing medico-legally correct, ethically correct? Because we are not sure that how much dose we are using it. Mostly, we don't encounter complications, but if we do, are we answerable?
This is a great point, Dr. Dalal. I completely agree with you. And we don't know, even if we know how much we install. When we install it in the trachea or in the vocal cords, we will also automatically suction it, right? So you install it and it's like a reflex, and then you suction again. So from this, what comes in, I don't know if it's half, if it's 1/3, if it's 2/3, what stays in the patient and what's the amount that is absorbed. So I'm sure we are not. We are using also 2% local, but I never know exactly how much stays in the patient in the end. So I don't think we are covered. And if something goes wrong and we have arrhythmias or something else, I'm not so sure that we are covered.
Recently, one of my patients had a bad seizure. So I'm I mean, I've just encountered a couple of situations like this, but one of my patient had a seizure. So, I mean, this is what I just wanted to know. Are we really responsible? Because we normally don't tend to calculate the dosage.
I think, ma'am, the best thing is that.
Yeah, Dr. Mohit, you're saying something?
Yeah. So I think sometimes, we open a single new ampule for the patient, and we know that what amount of exactly we are using it. So we don't use from the other ampules. We have a single ampule and we can use that. And that we know that it's a 30 ml ampule and we are using the amount of drug we are using. And then we have definitely some very rare, but you have seen a lot of CNS toxicities written on the documents or the literature. We have seen some with the lignocaine toxicity, even with, not the amount which is described at 3 to 7 ml per kg of body weight, even less than that. I think we should be looking for any kind of CNS symptoms that patient have, including twitching to seizures. I think probably that can save us if we just take care of the symptoms happening to the patient. So let's move on to the next question. So we have Dr. Nishanth and Dr. Vijay with us. So Dr. Nishanth, what tools and drugs you prefer on your trolley when you going for a bronchoscopy and you expect any kind of a bleeding from lungs? Maybe it's a tumor or it's a vascular origin bleed, or even you're going for a lung biopsy. So what all you need at your side?
Yeah, first is like to start with, as Konstantina ma'am said, first is a trained nurse who should think in the same line as you think. Otherwise, the team should be like pre-discuss that what you are going to do and what kind of complications you will expect in that patient, because complications are to be anticipated, and the tool should be ready even before you start the procedure. So first of all, I think you should have cold saline with you in our Indian scenario, where even tertiary or third tier cities, where these procedures are carried on, cold saline is a wonder thing, I think. And you should have Fogarty balloon with you, which will help us in properly giving a tamponade. And also, I think when you are having a massive bleed, our that when our flexible bronchoscope, it will be just like a full, it will be like reddish or only reddish view you will be seeing, only bloodish. So you should have a conduit, a rigid bronchoscopy at your side hand, because then only because you are dealing in the airway, so you should at any point of time you should be able to secure the airway. So you should have a the rigid bronch at your side, or at least you can have a second operator at your side who can, if you're doing with your main scope, you have a second operator who can with your ambuscope, you can have another bronchoscope inside, so that you can view what is happening. Otherwise you will be totally losing your the field of view. I will say that cold saline, then obviously ADR, lignocaine with ADR, adrenaline, which can have a good mucosal bleed control with its mucosal. Then obviously, then our endobronchial, the blockers, ant blockers, and the Fogarty balloon, which can give a tamponade effect.
So my question to Professor. So what about the use of endobronchial tranexamic acid along with your ADR, lignocaine, cold saline? How much help does it give it to us?
We do use it in big bleedings, but as Dr. Nishanth said, we will start with ice water with cold saline, try to cause this vasoconstriction. We will, depending on how the bleeding is reacting with these measurements, then we will go to the second step. We use, if it's a central bleeding where we see, and not a bleeding from a transbronchial biopsy, for example, if it's a bleeding which we can read, we don't use adrenaline anymore, or we used in the past 10 years we use, do you know the nasal spray Otrivin? This is xylometazoline chloride, and this is a vasoconstriction for the vessels. So we use a lot of this locally. And what we would do with the bleeding, central bleeding, is really get a big gauze and exert pressure locally. So either with a round, we say Tupfer, something as a round gauze which we push against the mucosa, which is the place which is bleeding. In this time, we will try to get the tranexamic acid ready, and then we will install it locally and also IV, depending on the case, depending on how the bleeding is responding. So this is a step-to-step procedure, not everything all at a time. But we have also balloon, a central bleeding from a small artery. We will definitely use the balloon to exert this pressure to stop the bleeding. And we need to think about these 4 minutes that our coagulation needs to form a coagul there and stop the bleeding. So it's these are 4 long minutes. But we need to find something to stop for this time the blood coming out.
So if I may add, for especially when we see these tumors like right pain, left pain, right upper lobe, that they appear quite vascular. What I really don't know whether that's the norm, but what I would usually do is, in anticipation of bleed, I would really put the patient on a dependent position where I'm going to biopsy. At least that would prevent any spillage to the contralateral lung while I'm doing a biopsy. As an anticipation, before I take my first bite itself, I put the contralateral lung on the higher position. At least helps to stem the bleeding, helps to control spillage to the other side, and then handle the bleeding. If there is any, that is one small thing that I would do if I anticipate a large any bleed from, especially to these tumors when we biopsy tumors.
So my next question to you itself, Dr. Vijay. So how do you manage your patients having a severe bronchospasm or a desaturation while you're performing a bronchoscopies?
That is something that we see quite commonly. Post bronchoscopic bronchospasms and all that, especially after lavage or something.
During the procedure also.
Yes, during the procedure. So most importantly is that patient monitoring pre and post. Pre-procedure, during the procedure, and post-procedure, patients need to be monitored. At bare minimum, you need a pulse oximetry at minimum, and BP monitoring. If you have ECG monitoring, that's even better. And during the procedure, at times, if we feel that the patient has risk factors, say underlying COPD or asthma, even from the OPD itself, when we are examining the patient, we would prefer to keep such patients under control first. If we see that they are quite symptomatic, we would, if we can, defer the case till a later time. But if we take them up and they happen to have, then what we do is immediately we give IV hydrocortisone injection, and then about the procedure, if it's in the middle of the procedure, about the procedure, whatever happened, and we will analyze and observe the patient, stabilize, and at the same time take a call to the ICU just to be ready, just in case.
So, Sonia ma'am, so do you think anything? Sonia ma'am, do you think that any acetylene used through your bronchoscopes mixed with saline can help it?
No.
Anything else we can add? An ADR can help?
No, so if there's a bad bronchospasm, the only thing is that you will have to
be something else. What's your take?
If there is a bronchospasm, you need to, sort of limit the use of the saline quantity. Wait, that is very important. Give a systemic hydrocortisone to the patient. Wait for some time. And if there is an hypoxia, then you need to act. Then you probably will have to ventilate the patient well. But if the patient does not have hypoxia and only bronchospasm, wait for some time, give hydrocortisone, And I mean, you can limit the use of a normal saline, the quantity of the normal saline, because that's the thing which is irritating and causing the bronchospasm. And if the patient is already having an airway disorder, in that case, you are preemptively ready. What you have to do, sometimes we have to do a bronchoscopy through a NIV in a patient when we know that the patient is going to go into a bronchospasm.
So let's move on to the next question. Hello. Hello, I'm So, Dr. Nishanth,
Yes, sir.
I think there is some disturbance from somebody's speaker, so we can put everyone on mute because we are having a lot of disturbance. So, Dr. Nishanth, so during any cryo lung biopsy or a conventional transbronchial lung biopsy, your patient gets a pneumothorax. What signs will warn you? Or what will be always keep in mind that, any patient can have a pneumothorax. So before it goes into an hypotension or a respiratory arrest, what signs you will see to that patient that, yes, this patient has got pneumothorax and I should act as soon as possible?
Yeah, like that's a little tricky question, but obviously, when there is a minimal or pneumothorax, initially I think like you can there can be tachycardia initially, or if it starts desaturating at ekdam starts desaturating. Otherwise, what I will tell you in a clinical way is if you can have a C-arm with you, or if you can just have a post procedural one shot of an x-ray at your suit where you can directly see what is happening inside. Otherwise you can just have a one short C-arm, one shot of the lung where you have done the biopsy. You can have a clear picture of what has happened. Otherwise, yes, obviously there can be tachycardia, and if it is hypotension and all, if it is going, there can be it's a massive pneumothorax. Anyway, obviously you should have because when you are doing the procedure, I think you will be having tachycardia, and you should have your assistant who is closely monitoring the vitals of the patient. Yes, obviously you should see the pulse rate and the saturation, and the other signs will be more prominent if you are having a moderate to massive pneumothorax. I think the team will accept that having a C-arm with us will make the things more easier. That what has happened the lung after you took biopsy.
Professor, what will be your take, ma'am? Professor Konstantina, what will be your take here? Somebody or patient gets a pneumothorax on the table.
Take it out and make sure if you have fluoroscopy in the room, and check the lungs to make sure, and auscultate, of course, the patient, and then try to support. I don't know, in Germany, a chest tube is put from the surgeon, thoracic surgeons, and not from the pulmonologist, which is not the way I have learned it. But in the end, you just need to release the air. If it's a massive pneumothorax, you just have to, if you're sure which side is affected when you do the transbronchial biopsies on the right side, and you have a confirmation either with fluoroscopy or auscultation, then we just have to remove the tension.
Mohit, can I add something to this?
Yeah, sure, ma'am. Sure. Why not, ma'am?
So the real problem arises, when the patient is breathing on his own, when the patient is having conscious sedation, you can always diagnose if you're doing under a CM. Now, the thing is that you're not using a CM, or in fact, even if when you're using a CM and the patient is under general anesthesia, that's the problem. That's the time you take a first bite, right? And if every time you're not going to look activate the CM and see whether the patient has developed a pneumothorax or not. So how do you diagnose that the patient has developed a tension pneumothorax? So very important for all of us to know is we have to look at the ventilatory parameters, because when the patient is completely sedated and completely under anesthesia, there will be rise in the peak pressures on the ventilator. Sudden rise in the peak pressures, hypoxia, and the tidal volume would go down 50%. So those are the things when we see, when the tidal volume goes down in spite of what you have set on a ventilator, and the peak pressures are very high, and then you just constantly get the PEEP alarm, That's the thing that you have to think, no, I want to activate my CM and see. If you have an ultrasound by the side, you can just put in a probe and see whether you have a, absence of the sliding pleura sign or not. And that's the only thing. The patient is not going to tell you anything that I have got breathlessness. A patient is not going to tell that I've got an excruciating chest pain because he's completely knocked out.
Well, point very well taken.
Absolutely, ma'am. So once the patient is conscious, he can tell you there is a pain. You can easily see that he's having a difficulty breathing. In a general anesthesia patient, definitely you look for a chest movement, then the parameters, and then whether you have a CM or your ultrasound machines. As Professor said, you have to release the air. So next question, Dr. Vijay. So what risk consents you explain to a family when going for a foreign body removal, and what tools you prefer?
A very good question, sir. I just had one last week where we had a 7-year-old boy who was playing in his garden and he saw a metallic object. So luckily the child came to the hospital within 3-4 hours, and he had initially gone to another hospital. They didn't have the facility, so they ended up in our hospital. And so when we saw the X-ray, it was lodged in the right intermediate bronchus. And being a child, that gave me added complications with just 7 years. So I spoke to the parents and explained to them that first and foremost, the best technique would be to take the child up under general anesthesia. So that would be the best approach. And at the same time, when we discuss these with the parents and the family, we also explain to them the possibility that there may be a chance with bronchoscopic retrieval, and the child may require a cardiothoracic intervention, surgical intervention. So for most foreign bodies, when we counsel the patients and their family members, we always keep that option open, that if endobronchial procedures fail, they may have to be subjected to a cardiothoracic surgical intervention. And for me personally, even when I perform my procedures under general anesthesia, I always involve the cardiothoracic surgeon. Usually he's always there and we usually do it in their OT, in the cardiothoracic OT, so that if any untoward complication were to happen, at least they can intervene at the earliest. Because as ma'am has already said in her presentation, time is of the essence. And any complication, we have to act fast. So the basic thing is what I expect my patients is that we will try bronchoscopic under general anesthesia, but if that fails, there's always a chance that the child or adult may require an opening of the nasal cavity.
Professor, what will be your answer to this question?
Thank you for this question. I can share with you an experience that I had in my first on-call, which was an 8-month-old child with aspirated a piece of like a toy. In those cases, if we have young, very small children, we should not use any saline. We just desaturate in seconds. This was this is a horror thing to see a child not use at all. Try to stay as dry as possible. I like the basket a lot. We have always, when we know we will have a child, we have always 2 anesthetists in the room, and the surgeons are standby, and also we have 2 nurses. We call extra another nurse. So we need as many from the personnel, from the team as possible there. And I like to stay as dry as possible. I like the basket a lot for plastic, yeah. But for if it's like organic substances, you remove them most of the time with a cryo. Also dry, no fluid, and always give it a first try to aspirate it with a bronchoscope. Sometimes if it's not stuck, you can just smoothly, only with rigid bronchoscopy, of course, just smoothly remove it only with suction and forget everything else. So sometimes we are also lucky enough.
Right, ma'am. So we have to explain every tool can be required to use, from your rigid to flexible bronchoscopes, and sometimes maybe a surgery as well. And patient may be on a ventilatory support as well. So in we have time audience also. So let me ask a last question to all of our panelists. So what backup tools, doctors, drugs, doctors mean specialties, you want to have in your hospital when you're dealing with an undiagnosed cavitary disease which is bleeding, and you know that it may bleed worse when you do a bronchoscopy. So what all background or a backup you will be requiring in that kind of a status, which we, I think, often see that cavity bleeding, whether it's a fungal, bacterial, I don't know, whatsoever it's gonna be. So how do you deal it? How do you start with? What scans do you prefer first or later? What kind of specialties or subspecialties you need at the background that in an emergency you will be needing help of them? So how do you proceed from there?
Can I add some points, sir?
Sure, please.
Yeah, first of all, like if it is a planned procedure, you need a like HRCT with a like iotogram, or what you call the bronchial artery mapping. If you can have a like proper thoracic iotogram, so you will know that if there is any bronchial artery which is dilated, tortuous and all, and having a proper interventional radiologist who is trained in bronchial artery embolization or BAE, so they can have a like add value to your team, so that it can be the artery which is bleed can be embolized. And obviously, as told by my like fellow Dr. Vijay, like having a cardiac CTVA surgeon with you makes you more confident that the doing in an OT backup where your like the minimal invasive procedure, that is bronch, can be converted into a surgical procedure at the same OT, that shifting the patient to another procedure room or another case space takes time, because at that time is everything. So I will tell an intervention radiologist who's trained in BAE with a CTVA surgeon, and also your like trained if you have a anesthetist who is well trained in an airway, because what I feel is all anesthetists are not very comfortable in dealing with airway. They feel that airway, if you they are not very comfortable, they are very comfortable in giving GA or in giving spinal, but when it comes to anesthetist who is trained in airway, that really adds value to a team.
Okay, so what's your take, Professor and Dr. Sonia, ma'am? What all you will be needing?
For a very big bleeding, the most important thing is to know which side it comes from, and if we cannot interventionally stop it, and we're not really successful, double lumen tubus block the orthography on the side which is bleeding, block this side. In endoscopy, clear the other side, free the other side from coagulation tissue, so we are able to ventilate this side, and we leave the patient intubated. He doesn't wake up, and he either goes, as Dr. Nishanth said, to the interventional radiologist for embolization after, if we have the arteries, bronchial artery, which can be embolized, or to the surgeons. So these are the two specialties who can take over if we cannot control a big bleeding successfully.
Sonia, ma'am, you're already into this.
I'm just leaving. Yeah, I'm going. So isolate the normal part. Very important. Isolate the normal part. Ventilate properly. Establish a good conduit, which is very important. Manage the airways, as Dr. Nishanth has rightly said, that you need to actually ventilate the patient well, maintain the oxygenation, maintain the ventilation. Then you must, if you can control with topical cold saline. If you can use the blockers, you can use your scope itself as a which can probably help you in stopping the bleed. You can use a Fogarty catheter. You can also use, if you can localize the bleed at one point, you can use the other modalities like APC or an electrocautery, and you can use a Svigot. Those are the things. If you cannot, right, you wait for some time. If you can control the bleed, fine. If you cannot, you must have an IR as a backup, provided you can isolate the bleeder through the aortogram from the CT scan, and then they can do a bronchial artery embolization. But you also have to inform your cardiothoracic surgeon. You might have to take that patient for the surgery as well. So this is, this has to be as a protocol.
Thank you so much for the insight, ma'am. Dr. Kanishka, I think we have a lot of questions from the audience.
Well, I think
Dr. Kanishka to take over from, because we can.
Yeah. Thank you, Dr. Mohit. And I think the voice was lagging, but I understood what he was trying to say, that to take the audience question, because we are coming to the end of this program. And first of all, I'd like to congratulate you, Dr. Mohit, and Dr. Sonia, for bringing out and representing whole of the interventional pulmonologists, because these are the questions which have, comes to everybody's mind, and through you we are able to get the answers and opinions of our international and national experts and panelists. So thank you so much, Dr. Mohit. Thank you.
Thank you.
So now we'll be moving on to the audience questions. And I'll start with a question from Dr. Shreyas from Maharashtra, Kalyan. Is there a role of IV derifylin in case of bronchospasm with hypoxia? I think it's a very intelligent question, but I think maybe some refractory use is there. What do you think, Dr. Nishanth? The short and quick answer.
Derifylin has a very narrow therapeutic window. So derifylin causes tachycardia and it can trigger arrhythmia. So I will restrict using derifylin in those condition. If you can restrict yourself to nebulized drugs or hydrocortisone, that will be much better.
So we can always keep that as a as a refractory thing, the IV derifylin, if we fail to bronchodilate with all these nebulizers and everything. Perfect answer. Thank you so much. Now, Professor Kontogianni, ma'am, you have already answered this question in the chat box from Professor Saurabh Karbakar. He's a professor in Patna, Bihar, AIMS, All India Institute of Medical Sciences. But for the audience, I just want you to repeat that for everyone. How well APC works as a debulking and recategorization modality in mainstream bronchus growth? How safe vis-a-vis cryo? How commonly laser therapy is used?
So APC, I would not say this would be not the first modality that I would use in a big debulking. Cryo is the easier way, or mechanical debulking. APC works finer. It carbonizes and vaporizes tissue, but only, so I would use it in the end after finishing a big debulking with a cryo, for example, and then coagulate and also smoothen the whole trachea, for example, or the region of the obstruction. So not for the first tool to start with. And it is safe because it's coagulating. And if you are trying and if succeeding with the non-contact, then nothing should go wrong. It does not. There are different. The newest ones also have different. We have pulsed or continuous, and we have also different intensities of APC. So we can go more aggressive and more cutting and vaporizing than only the coagulation APC. So we are much more flexible now. I think this is a really good modality. Cryo is easier. We can control it. The longer we freeze, the bigger the chunks of the tissue that we have, but this can bleed. So most of the time in real life, we use both combination. We work with the cryo, then coagulate, then work with the cryo again, then coagulate again until we are happy. This is how we do it most of the time. And think, please, if we have a big bleeding, APC is not going to work. APC with a lot of blood, it's not working. It's coagulating only the blood in the airways and nothing else. So it's no coagulation effect there. And the laser is really still very, very expensive. So we don't have laser, for example. And this is the most important factor for this. I think it works well, but I haven't worked with it, to be honest, because of the costs.
Thank you, ma'am. So, the next question from Dr. Hardeep Chatterjee from. So, I'll ask Dr. Mohit, tamponade with scope can be tried first in non-major bleeds or not?
Hello. Yeah, Kanishka, sorry. Can you repeat the question, please? Sorry.
It's a quick question. Tamponade with scope can be tried first in non-major bleeds when you do a bronchoscopy.
Yeah, surely you block that segment. You are almost giving, a natural kind of a coagulation. So you block that segment, let the blood to clot, as Professor said, that keep it for 3 to 4 minutes till it gets a clotting time. It can give you an upper hand. And specifically, if you hold that segment, you may not lose the visibility and your other bronchuses or the airways will not be filled with the blood. It's always a good practice to keep it. And further, if you want to instill something, a cold saline or a local adrenaline, you can do it in the same segment, keeping your scope very stable at the same position.
Thank you. Ma'am, coming to you, how can a single-use bronchoscope change our practice? It's a question from Dr. Chinkita Agrawal from Uttar Pradesh, Noida. Do you have any... I know there are a lot of reusable bronchoscopes. What's your opinion on single-use bronchoscope? Do you think it's practical?
I think they are very good, to be honest. The new generations, they look almost and work in the same way that the reusable ones. And also, like, turning the camera is possible of the tip of the scope. So I'm really impressed from the new generations. The image is perfect anyway. What makes a difference in emergencies is that I would be not that careful as I am with the reusable one. So if I have the APC, who cares if I burn the tip of the bronchoscope? So I will come closer. Maybe if I don't have good contact, if I have contact, I will draw the probe back. So I'm gonna be more trying to be more closer to the scope in order to have a good result. And I don't really care what happens with the scope. We're gonna throw it anyway away afterwards. So this is, I think, a nice thing from the single-use bronchoscopes.
Thank you, ma'am. Dr. Nishanth, what is your opinion about the concept of mini bal in hypoxic patients? How it is different from, I think, must be trying to ask about the sterile catheter, which we, put it through the tracheostomy tube just to get a blind bal. What do you think about the mini bal technique?
Like, actually, it is about, are you going to gain with the mini ball, or whether you're dealing with an infective pathology. Because anyway, if you put like saline in the airway, there is more chance to the patient going hypoxic. So if you really want some get an infective, then rule out tuberculosis, rule out fungal etiology or any secondary bacterial infection, then the concept of mini ball takes importance. Otherwise, in emergency condition, going for a mini ball will make things hypoxic more worse, I think. Is it really needed, or what are you in your back of your mind? Like, is it adding any value to the procedure? You should have a clear picture before you are genuinely want mini ball or not.
Okay, I think they must be asking about the patient is very hypoxic and you cannot do the bronchoscopy, then you can just put a sterile catheter.
Yeah, I think the question might be that way. If it is like mini ball, will be able to aspirate the contents or that, because I think while doing mini ball, you are not knowing where you are taking the content only. It's just a blind procedure.
So, ma'am, the question to you, you mentioned about the role of oxymetazoline and topical Trenexa and adrenaline. Dr. Satvik Manchanda from Delhi wants to know about the dose, if any dose is good for, or dilution is good for xylometazoline, oxymetazoline or Trenexa.
We use 2 milliliters. And flush it with a lot of air, because 2 milliliters then stay in the bronchoscope, of course, in the working channel. So we really have to flush it with a lot of air, the bronchoscope afterwards, in order for it to come down to the bleeding where we want it. But it's really safe if you it's safer than adrenaline. Let me say it in this way, using locally adrenaline. So we have no problems with the pulse using this one. And you don't need a lot because it's really working nicely locally. So I think 2 milliliters, this is what we do, and not body weight of patient, and so simple 2 milliliters installation and finish, and wait until it also does this local vasoconstriction. Yeah, this is our practice, at least.
Thank you, ma'am. There was one question from Dr. If it is necessary and it's high risk, should we go ahead with the rigid? Ma'am has already answered it, that to my opinion, yes, with rigid we have a secured airway and the whole time, and an anesthetist is there who takes care of the patient. So of course, rigid is preferable when you think it's necessary and high risk. So now coming to the last question, Dr. Mohit and Dr. Nishanth and Professor Ma'am, in bronchoscopy, we trained in techniques, but not in failure management. Do you agree with that? And do you think complication training should be a formal part of pulmonology curriculum?
I think complications is something which you deal and you learn. And then in today's world, I think simulation things can better teach you the complications rather than we can't have complications prior to, for the teaching part. But it just comes to your way and you keep learning. I think the probability is that you need to learn the basics first. And when you know that, you can always have a upper hand on the complications. But I think simulation could be a better answer to these questions, that simulation can teach you much better and you can perform your complications as well there. I think that could be more helpful.
Dr. Nishanth.
I think Professor can answer better.
Yes, one thing to add, like complications are to be anticipated so that you will be equipped to prevent. And as Dr. Mohit sir told, that simulation training will be better, but real life situations are different, because simulations like are you are very calm, composed. You are knowing that the patient is in the background, it's a dummy or simulation. But when it comes to live case, it is actually your experience which counts.
Ma'am, your last words on this.
Completely agree. We go first with simulation and then on patients, at least for the technical skills, yes. But the real thing is on the patient, where we are sweating, we have a high pulse because things are happening and we want to control and save the life of the patient. These are life-threatening situations. I think, like Dr. Dalal said before, standard operating procedures. This is SOPs. These are the most important thing, especially for the younger doctors, to know the steps, at least have read about this, and then with the experience in the endoscopy room, this is where then we really get to have skills and being able to deal with it calmly. We have to stay calm in such situations. This is very important. If we lose our concentration, if we lose ourselves or our control, then we will cause more harm to the patient.
Thank you so much. I think this is a very important message for all of us, that interventional pulmonology training it goes beyond the stipulated time period which we do in India. Learning goes on, and experience is the thing which teaches you. You learn with the patients, grow with the patients, and then you teach to the other fellows who are coming up, becoming interventional pulmonology. So one last line message from all of you. Dr. Mohit Kaushal, just quick one-liner from your side to the audience. We'll be closing this session up.
So learn the skill before you perform, and you should do what to do and what not to do. I think this will be the answer that to tell you with your complications and the diagnostics.
Dr. Nishanth.
Yes, that is the final line which I want to tell also. When not to intervene and when to do, and always the patient safety should be first always explain the patient what you're doing, and the consent is really important because whenever practice is getting more and more like getting into the what to say this commercial or this I'm not getting the word, that legal point of view, you always consents carry real importance, and explaining the patient what you're going to do and what outcomes will be there with, so that the bystanders will be with you after the procedure also.
So you mean to say that, of course, take care of the patient, but take care of yourself as well.
Yes, obviously, because you have a life with you also.
Yeah, that's very important. So, closing line, we'll close this with Professor Kontogianni's last one-line message line.
I have to be honest. I will tell everybody just maybe, of course, do the training, do the simulation, read everything, know the SOPs, but also follow the PACS episodes. I think it's really good teaching material, and we can all learn, no matter how experienced or non-experienced or less experienced we are, following those meetings that you are planning. I find them really, really important also for younger doctors to follow and learn like this. So thank you very much for having me here.
Thank you, everyone. Thank you, audience, for listening to us. And we'll be back with another episode next month on the second Saturday. Thank you so much.
Thanks, PACS
Thank
team,
you so
for
much.
having
Have a great evening.